we've been sort of talking about the most extreme cases that now with patients with RV failure, severe hypoxemia, potentially cardiac arrest, but particularly with patients with severe hypoxemia, obviously putting patients on extracorporeal membrane oxygenation support or Ecmo support is one strategy that some hospitals have. What are the criteria that you use, Dr. Hawkins, at your institution to make the decision to put somebody on Ecmo?
So Ecmo is sort of something that early on was thought about as a rescue strategy for patients that had, this profound upper respiratory illness and refractory hypoxemia when we were not able to meet our lung protective vent strategies and such. And on the heels of some, mixed data from previous respiratory viruses and ARDS trials looking at Ecmo and whether or not it was really a good strategy. And then early on, the reports from China had a huge mortality range of anywhere between 30 and 90%. Resources were very, very slim at the time, running out of ventilators, running out of people to take care of, healthcare workers to take care of patients. And a report came out in the Journal of Critical Care that said, on ECMO, these patients had close to a 90% mortality. And so, that was certainly disappointing, but there's a lot of heterogeneity around the world. And, it was a bit discouraging, but didn't stop us from continuing to try. And then in October of 2020, the Extracorporeal Life Support Organization, which is an international organization that maintains a voluntary registry of ECMO patients, reported their findings of ECMO use in COVID, looking at over 200 hospitals worldwide, almost 1,100 patients. And they reported a mortality in 90 days that was only 37.4%, which was fairly similar to the most recent ARDS ECMO trial, the Eolia trial that we have. And this data was published in a Lancet article in November of last year. That was, again, it was 1,100 patients. There's now almost 8,000 patients in the registry. And, the sort of second wave and as more patients have come through, the mortality now is closer to 50%, which I think is probably more on par with what most of us are seeing. The indications for cannulation really are profound hypoxia. So average PF ratio in these patients was about 70 when we're concerned that the ventilator is doing harm. So if we can't maintain our lung protective strategies, our plateau pressure is less than 30. If we can't ventilate these patients, certainly is time to think about ECMO, but we have to be very, very careful. And we know that there is higher mortality in patients that are older, that have a lower PF ratio, that have organ dysfunction prior to going on ECMO, so acute kidney injury, things like that. We do know from, it's one of the few things that we know when it comes to ECMO for ARDS is that the earlier you go on, the better you will do. So, certainly nobody who's been on a ventilator for more than 7 or 8 days, that's a criteria that we use here. We know that from the data that we've looked at from the ELSO registry that the earlier you go on, the fewer comorbidities you have, you'll do better. But that sort of begs the question of what would have happened if they didn't go on ECMO? These were healthier patients with less severe disease. Would they have survived regardless? And that's sort of a difficult question to answer. The other thing to think about is from this also an initial study that even though 57% they said were discharged alive, many of those were discharged to an LTAC or another facility. So what's really the long-term outcome for these patients? What kind of neurologic sequelae do they suffer from? What is their quality of life? How much weakness, PTSD, things like that do they have? Sometimes the media portrays very rosy pictures with these life-saving therapies, but those of us that practice in hospitals know that that's not always the case. And we do know certainly that it is a tremendous resource that requires a multidisciplinary team, a lot of equipment, perfusionists, nurses, equipment, all kinds of things. So, that's something that also has to be considered. If you are at a place that does not have the ability to do extracorporeal support, one of the things you want to think about is when to transfer a patient. And it's important, especially in the time of a pandemic, to have a network and a referral strategy, hopefully within some kind of organized system. So knowing who to call and having easy access to that person or that facility's phone number, knowing what the outside hospital, what their preferences are, what their requirements are for, or their criteria for putting people on. And the criteria has gotten more and more stringent as the pandemic has gone on. Many centers won't cannulate anybody over the age of 50. Over a BMI of 30 or 35, any organ dysfunction, people have gotten very selective as the outcomes have been plus minus, and as resources are waning. And then if you're a receiving facility, obviously having a coordinated process daily, knowing what your resource capability is with your nurses, your perfusionists, how many pumps you have, so that when the physician or the transfer center or whoever it is that receives a phone call saying we have a patient we want to send, everybody is in the loop, and knowing what our capability is of accepting a patient for ECMO on that day. Something else that we have to make sure that we pay attention to with these patients is setting realistic expectations with the family. ECMO is a support, but it's not a therapy. It's not going to treat the COVID. It will hopefully give time for the body to heal itself. So this is not a therapy, and the family has to be given realistic expectations. Timelines need to be discussed, so that patients don't suffer in the end. And that is what I have on ECMO.